So, what are your thoughts on balancing sustained treatment intensity with quality of life considerations and long-term management?
Yeah, it has been, especially when we were setting up this trial, which is now dating back 9 years ago. We were using very new drugs that no one knew actually what they would do to the patient if you give them continuously as a combination treatment for years and years and years. Um, I think it's important always to listen to the patient. Of course, I think all of the long term care does need a certain form of finding milestones in the treatment where you regroup with a patient and say, is this still also, what you feel is the right thing moving forward? I think we can always express recommendations, and we should do that. With a trial like the optimum trial that we've run now, we can give a very strong recommendation that should be the right treatment. But how patients experience side effects is very different, of course. I think we have hit a good sweet spot with this treatment in that really the majority of patients were definitely able to continue the treatment. And we have measured quality of life that we're analyzing at the moment, but the signal that the patient didn't have to stop treatment is, I think, the strongest one. Nevertheless, when you really use the treatment, it's a very common thing in myeloma that you can improve side effects of treatment quite easily by reducing doses, or let's say giving an extra week of break from treatment, and that often doesn't really impact the outcome. So it's really about listening to the patient and having a good relationship between the doctor and patient to find the right way.
Hmm. When it comes to, hold on a second. So, what specific drug combination or sequencing approaches show promise for high-risk patients beyond current standards? Is there anything on the horizon that you're looking at?
Yeah, I think we see a whole raft of new treatments entering the myeloma practice very quickly. Many of them are already being used in later lines of treatment very effectively. So mostly the T cell based treatments. These can be CAR T cell treatments or T cell engaging antibodies. They are now bispecific antibodies that are licensed already, but there are already trispecific antibodies in development. And many of these will have a different effect and a better effect on high risk myeloma than the treatments that we have available at the moment. I think it will really require them coming into early lines of treatment so that more patients can benefit from them, because we do know that in high risk patients, the disease sometimes or often just becomes more resistant with each time it comes back very quickly. So the patients at the moment don't get the full benefit of these new treatments. But that's the normal way how they are developed. We can't really jump massively ahead here. It's already in the making that we're setting up a lot of trials now with these drugs in first line treatment. And I think the outlook for many high risk patients will change fundamentally through that. Having said that, we already see the benefit of that with the patients, for example, that are relapsing at the moment from the Optimum trial. We have already extended their progression time so long that they are benefiting now from trials that use, for example, these T cell treatments in second line. And we see many of these patients going into excellent remissions in second line. It's something that we haven't seen before. I think there's a real hope that we can improve the outcome of many, many lives of patients with high risk myeloma.
Mm.